لان هي من اقتراحه، واعتقد انها هتبقى يعني مستحسنه جدا منكم. الحاجه الثانيه، عايز انبه ان كل المحاضرات دي بتتسجل صوت وصوره، يعني هتدخل بعد كده على الصفحه بتاعه اسم جراحه العظام، هتلاقي كور ده بيبقى عليه كل المحاضرات، هتلاقي صوره سلايدز بتتقلب، وصوره كمان للسبيكر وهو بيتكلم. فانت كانك حضرت الكورس تاني، هتقدر تراجع كل كلمه، هتقدر تسمع كل ليكتشر انت انترستنج فيها او عايز تسمعها تاني وانت في البيت، فهتبقى حاجه كويسه قوي. continuing teaching and learning. ان شاء الله باذن الله بكره مش هنبقى شغالين في القاعه دي، ان شاء الله هنبقى شغالين في القاعه اللي هي في الارض، القاعه الكبيره قوي، لان العدد كبير، فعشان تبقوا قاعدين براحتكم. اوكي، نبدا ان شاء الله. دكتور محمود.
متشكر جدا دكتور هشام بيه. السلام عليكم. الحقيقه السيشن دي احنا ضفناها السنه دي، والحقيقه ده ما كانش اقتراحي انا، لازم ننسب الفضل لصاحبه. انا كنت عامل ميتنج طبعا غير دكتور هشام بيه السينيور الجروب، مع اخويا وزميلي محمد جبه واحمد فؤاد. ومحمد جبه اللي قال دكتور محمود عايزين نعمل تويستنج شويه في الكورس، وهو اللي اقترح نحط الريسيرش سيشن، واحمد فؤاد برضو كومنتد. فالحقيقه دي كانت فكرته هو مش فكرتي انا. احنا يا جماعه النهارده ان شاء الله اكبر الله اعظم ونزات، احنا ان شاء الله كلنا يا جماعه بنلاقي صعوبه في الريسيرش والستاتستكس. by the end of this session we hope ان يكون الحاجات اللي احنا عارفين انها known to be unknown بقت known to be known. اوكي as much as we could. انا هبدا الاول. may I ask any one of you just to brainstorm in the start. تقدر تقول لي حضرتك ايوه what is the systematic reviews؟ طيب حضرتك ايه systematic review؟ could you make a definition؟ put a definition for that؟ طيب باشا systematic review. طيب سؤال تاني اسهل، حاجه اسهل بقى كلنا عارفينها. برضه انت عشان المحاوله الثانيه. What's double blind study؟ يعني ايه دي؟ سهله. طب ازاي وانا جراح هبقى third partner اللي هو بنسميه الاسيسور؟ تقريبا بس هو مش دي الاجابه اللي انا عايزها. هو الحقيقه double blind study يعني two orthopedic surgeons reading ECG. We're looking at that, it will be considered as double-blind randomized study. كل حاجة يا جماعة generalizations، شكرا. Generalizations are always incorrect, including that one. مارك توين قال الجملة دي، وعشان الجنراليزيشن are always incorrect، فالحقيقة دكتور محمد تاج زميلنا أنا أتحدى إن ممكن يقرأ الإي سي جي أحسن من كارديولوجيست كتير، بالعكس ويعلمه لهم. فالعبارة دي صحيحة على بعض الناس. طيب this is very important topic يا جماعة. In the 21st century, clinician who cannot critically read a study is as unprepared as who cannot measure the blood pressure. شايفين يا جماعة؟ يعني it's totally unaccepted دلوقتي. This is BMJ 2008. It's totally unaccepted. ما فيش حد فينا مش مفروض ما يعرفش يقيس الضغط حتى لو كناش دكاترة بطنة. فactually as likewise if you can't review the paper and understand it, appraise it correctly, يبقى احنا في الحالة دي أكننا ما بنعرفش نقيس الضغط. Learning outcomes, I hope by the end of this lecture, we would have covered what's meant by evidence-based medicine and why we do evidence-based medicine. Steps. We are going to know how to construct or formulate a question using what we call PICO. It's not PICO, عشان هتشوفوا ليه. It's PICO and sometimes we add the T to that, and we are going to discuss that as well. What about the pyramid of the evidence-based medicine, the study types and designs, and then the take-home message? Right, to start with, what's meant by evidence-based medicine? The classic or the original definition, it used to be the conscientious الضمير explicit صريح for those who might not know the words. Judicious use of the judicious حكيم أو عاقل of the current best evidence in making decisions about the care of individual patients. لقوا إنه actually evidence based medicine whenever you need to integrate both clinical expertise بتاعة clinician as well as the best available external clinical evidence. لقوا إنه ده كان سنة 1996. لقوا إنه هو it's a little bit deficient. فالديفينيشن الشامل الجامع الجديد إن أنت whenever you need to integrate 3 words 3 statements evidence the best available research evidence مش بس كده clinical expertise بتاعة physician أو clinician in addition to the patient values. لازم patient values to be taken into consideration preferences circumstances resources etc. فالثلاثي دول this triple including يعني ايه individual clinical expertise يعني in my experience and usually we refer to the senior surgeon senior clinicians and also exchanging mutual experience with other colleagues and taking their opinions. had authority like النهارده مشرفنا دكتور ماهر بيه حلاوه. This is considered to be a very experienced senior surgeon. In addition to that, you have to search for the best available clinical evidence in addition to the patient values. لما تيجي تعمل integration for these 3, look to the result, it's improved patient outcome. The ultimate care, at the end of the day, our goal, the ultimate goal is basically improved patient care, okay? So you have to integrate the 3, not only your experience, not only the evidence-based, or the available evidence, but also the patient needs, preferences, resources, etc. طب احنا ليه عايزين نعمل evidence based يا جماعه؟ Right. هو الاوبجكتيف بتاعت اي حاجه فيها included في الريسيرش الاتي. في 2 terms عايزين نعرفهم. حاجه اسمها eminence based medicine. حد سمع ده؟ In contrast to the other word evidence based. Eminence يعني like the senior colleagues, senior surgeons. Some of them are quite happy. They have a really a big faith in their experience. They always say, I've been using this method since many years. Some of them, I know what's best for my patients. And we call that eminence-based medicine. In fact, في another thing called eloquence-based medicine. They always describe them in UK like those with Armani suit, silk tie, putting carnation يعني قرنفلة في البدلة ولابسين أغلى ساعة و they look very elite. Whenever they start to speak and talk about evidence, without evidence, they are considered authority in themselves. And this is called eloquence-based medicine. But what we are here today about is basically the evidence-based medicine. And usually ask yourself, is the treatment I'm going to pose to my patient the best available option? Always ask yourself, is there any clinical study investigating this problem or saying some advantages about treatment or the other? Right. We have to take into consideration كلنا ذاكرنا من كامبل زمان and name whatever books. هل دلوقتي من ساعات whenever we read some info from these books, sometimes we say, well, it's a little bit outdated. Some of it became, I wouldn't say wrong, but not very up to date. حاجة تانية, in the other parts of the world, even starting to be in some parts of the Middle East, the insurance companies, they might not agree in some countries. What are you going to do to the patient? Is it evidence-based? Otherwise, they are not going to pay to you. Also, we have to take into consideration the litigation, the medical legal aspects. So every one of us in this room, in this hall actually, should go by the principles of evidence-based medicine as much as he could. But again, we are not going to forget the other 2 parameters we just mentioned. هما ازاي بيعملوا الsteps أو بيعملوا زي evidence-based medicine. If you don't ask, you don't get. فأي حاجة في الدنيا you have to ask for first. فبداية السايكل في synthesis of the evidence-based medicine starts from formulating a question. And this is the very important part. And actually أنا عملت التوك ده قبل دكتور هشام عشان يبقى in continuity لما يجي يشرح لكم how to write a paper. هتشوف إنه من أول الريسيرش question اللي انت بتحطه في الاول هو ده اللي هيتبني عليه، ولما ريفيور يقراها لو انت مش حاطط الاوبجكتيف through formulating a properly formulated question الموضوع بعد كده ما بيبقاش ماشي صح. You have to answer every single part of this question throughout the research paper or article you are going to write. Number one, the question. Number two, you have to search. Do proper search. All the available resources, networks, Medline, Embase, etc., colleagues, Cochrane database, NICE guidelines, practice guidelines, clearinghouse guidelines. And then you have to critically appraise whatever paper. يعني مش أي paper تقراها تقول دي حلوة أنا همشي بيها. You have to have the critical appraisal skills to know whether this paper is accepted or could add to the practice, or it does have some flaws, some weaknesses, okay? After that, you start to apply the results, and then you see the outcome, and then you audit yourself. Audit means to see when you apply this procedure or whatever you are going to take as a treatment, whether it works or not, and then it's continuous cycle. You have to criticize yourself. Well, when we've done that and audited the results and the outcome, we've seen that it's better procedure, so let's improve on that or let's build on that, or the other way around. So again, start with the patient with the clinical problem, and then pose an answerable question, find the required evidence, critically appraise, as we just said, and then act on the evidence. And then you repeat the cycle again. Okay. The most important part, we said question. So how to formulate question? Again, any study design, the basic design, would start with the patients or population. It's P. And then you treat your patient. We call it exposure to treatment or some form of intervention, and then, or the other, and then you get the outcome. Right. Building on that, you could say that the clinical question includes 5 primary factors. Population, which is basically the patient, and also then we come to the exposure. And as we said, the exposure might be one exposure or the other if you have comparison group. So it's patient, intervention, I in intervention, and then comparison, and then you get the outcomes. Some systems develop what we call PICO, it's P-I-C-O. And the other authorities might add the T, add the time frame to this, to be PICOT, right? As we said, the clinical question is very important to influence the study design. Let's go one by one. Population, patient, this is very basic, this is very important. We have to focus on the patient characteristics. You have to put in the paper you are going to describe the inclusion and exclusion criteria. It has to be clear from the start, explicitly declared from the start. Sex, age, medical history, etc. In addition to the demographics of the patient. I, for intervention, you have to describe the planned intervention, whether you are going to do surgical treatment, conservative, etc. Comparison, and some studies will include, as we are going to explain, comparative group. So you have again to define the planned comparison. You are going to compare some sort of internal fixation against some sort of arthroplasty, for example, or some sort of internal fixation against cast, against conservative treatment. Some studies do not have comparison group, at which point why we need to study that, we need to study about the safety, like if you are going to use a new implant, right? O in PICO is outcome, and we need to define the results using specific and focused what we call outcome measures. It's beyond the scope of this lecture, but anyway, whenever you evaluate the outcomes of any procedure, any conservative or surgical treatment, you have to use very specific outcome measures. And one of the most commonly used nowadays is what we call patient-reported outcome measures. Time. You have to add the time frame, because sometimes you need to measure the outcomes pre-operatively or before treatment, after treatment, 6 weeks, 6 months, etc. Again, you need to be very specific and focused. Whenever you formulate this question, you have to reflect that in the paper or article you are writing. Otherwise, the reviewer would say this is not properly done. After getting that, you have to take into consideration patient intervention control outcome and time. So who, what, how, when. These 4 questions you have to take into consideration, right? After posing this question or formulating this question, you start planning your study. And again, let me reiterate, whenever you plan your study, you have to refine the objectives to be covered, every single component of the objective to be covered in the question. So if you start the research with improper formulation of the question, everything will fall apart. But again, you need to refocus during the methodology and the results and everything. You need to make sure that you answered every single component of your question. Right. You said we are going to plan our studies. What different types of the studies we have? Studies in general might be considered to be observational or interventional or experimental. And the observational studies include different case series, cohort studies, case control. Hold on, Dr. Mahmoud. You didn't mention anything yet. Yes, I know. So let's start first by the observational. Observational meaning, as the term would imply, the researchers are going to observe patient groups. So they are not going to alter anything, any events. They are just going to observe that. This might be prospective, forward in time, retrospective, or backward in time. It might be what we call descriptive, wasfiyya, or analytical, where there might be comparison group. Right. What about experimental? So we said observational, we are going just to observe. Experimental, we are going, or interventional, we are going to intervene. We are going to expose our patient to some sort of maneuver, applying maneuver. And this allows comparison or evaluation of efficacies of different therapeutics. One example of that, basically, the double-blind randomized, not myself and Sharif Khalid, the proper double-blind randomized control trial. Right. What's meant by descriptive? It's basically just TOSIF and obtaining background information, like, for example, the frequency of this disease, natural history, etc. And this applies to the case reports, case series. Analytical, we need to find some sort of association between different factors or variables or confounders and the outcome. So basically, it's an analytical study, and it usually includes a comparison group. Examples, case control, cohort, and meta-analysis. Right. There are something called hierarchies of evidence. Anybody heard about? The very famous pyramid is basically called the evidence pyramid. It's a very important guideline to the hierarchy of study design. And as we could see here, I'm going to use the cursor. You will see that it has, like any pyramid, wide base and then narrow top. And basically, as you go from the bottom to top, the level of evidence, the quality of the level of evidence increases. So we usually say from the bottom to top, 5, then 4, then 3, 2, 1. As you could see, it's quite narrow up there, which indicates that, yes, it's higher quality, but we're still very early, so limited amount of the literature considered to belong to level 1 or 2. So as you go from down up there, you start to increase the quality, but again, you will notice that the smallest amount of literature available will be the high quality studies. Right. What does it include? From bottom to top, what we call first the in vitro test tube or animal research. Before applying any ideas, they have to try it in the lab. And then you'd go into ideas, editorials, expert opinions, which we call level 5 of evidence. Okay? And then you go into case series and case reports. Most of our work in Egypt, unfortunately till now, we start to have some level 1 and level 2, but most of the work still case series, which is basically level 4. And then you go into the other levels. Case control or cohort studies, as we are going to discuss, it's considered to be 2 or 3. And then level 1, where you could find the properly done high quality randomized control trial, in addition to the meta-analysis and the thematic reviews, as you correctly explained. We are going to show that. Right. So let's go from the bottom to top. What's level 5? It's basically called expert opinion. How could you find that? Either to speak to a colleague, personal communication, narrative reviews. Narrative reviews meaning ساعات يا جماعة لما بنذاكر حد يقول لك أنا هذاكر review article. الريفيو ارتكل ده ما بيبقاش لا يساوي كلمه سيستماتيك ريفيو. اوكي؟ ده حد بيجيب quite a few papers upon his judgment, his preference, and then starts to summarize the topic. It doesn't necessarily apply Lee statistics. It doesn't necessarily apply rigorous صارم اختيار صارم rigorous research criteria. وهو ده اللي هنتكلم عليه في systematic review. فthat's what we call narrative reviews. Survey of the practice. Narrative يعني حكاية بيحكي. فحد بيسرد فبيجيب البيبرز اللي هو عايزها وبيحطها. Survey of practice patterns, opinion pieces. Right. What's level 4? The commonest we use here is what we call case series. Basically, you get like, for example, you will study about case series of fracture acetabulum. You are going just to see the results or outcome and fixation of comminuted posterior wall fracture acetabulum without control group. You are going to follow these patients in a prospective study and to see the outcome. You don't have here any comparative group. Again, why it's low in quality? Because it might entail quite a few bias points in the synthesis. It could be prospective, as I said, if you are going to study that and take it forward, or it might be retrospective, where you might say, well, I'm going to study the outcome in the acetabular fractures, but through getting the patient notes in the hospital and seeing and just reviewing the outcome. So it might be prospective or retrospective. Everybody is happy about the word prospective and retrospective. Prospective forward in time, retrospective backward. Is it always a bad thing or very low quality? Absolutely not. Sometimes that's the only evidence available for you because you can't apply the randomized controlled trial in every single piece of medicine. Again, whenever we do cervical, for example, cervical fusion, using one of the cages, new cage, is it ethical to compare that from whenever it's brand new to other procedure? You might apply or just enroll your patients in a case series study just to study whether this is going to work or not. And then after you study that using the case series, you might build up on that and then start to compare it and make like prospective cohort study or randomized controlled trial. Right. Just one word, you might hear the word cross-sectional. It's not belonging to our work in orthopedics. It's basically useful to describe specific or specified variables and their distribution patterns, like the prevalence studies, and there is no follow-up. It's just to study this patient as a single occasion and short period of time. They call it cross-sectional, just you might come across. I forgot the case report. What is the case report? It's usually said to be around level 4 as the case series. And the case report is basically whenever you study one patient, whenever you see very rare outcome, a very rare procedure or very rare finding, and then you start to publish on that. And you call this case report. And usually it's around level 4. Right. Then we'll come to level 3, and we call, there are two groups of studies we need to differentiate. What we call case control study and cohort study. Believe me, some of the orthopedic surgeons might not know the difference. The case control studies, basically, you have to start to compare your patients with outcome of interest. So you are going to start with the outcome, that's the differential point, and then you go back, because it's retrospective, and to see the exposure, to study about the exposure. Which one has got the exposure to X, Y, Z? So you start with the outcome or the disease patient. For example, if you have some patients who have got the lung cancer, for example, and then you start to study those patients who has got some lung cancers and some did not. And then you start to study that retrospectively and to see whether which one of those groups patients were smokers or not. So you start with the disease, and then you retrospectively review the exposure, which is basically whether they are smokers or not. It's useful for rare conditions, rare diseases, less time consuming because it's retrospective, and less expensive. However, it risks for bias because not all hospital notes would, it's not easy to get all the data required to do this research, and difficulties in selection of the control group because this is retrospective. Right. What about the cohort study? Basically, you are going to study the patient, group of patients, and compare them on the basis of exposure. So when it comes to the case control, one word, I want you to remember outcomes first, and then you go to the exposure. And then the other way around in the cohort study, you start by the exposure. You classify, you study your patient on the basis of exposure rather than the outcome. Like if the patient having osteoporosis, internal fixation, etc. If we are going to compare to the other example, like the lung cancer, I'm going to say, I'm going to study patients who are smokers versus those who are not smokers. I'm going to see which one of those is going to have lung cancer. So the other way around. Just to complicate things. Cohort studies, unfortunately, it might be either prospective or retrospective. Prospective, we know that. Retrospective, now it might be a little bit confused with the retrospective case control studies. Again, the magic words, and I think Professor Magdi Ibrahim, professor in Ops and Gynae and also a great statistician, he's going to explain further on that. But basically, the take-home message, the case control study, basically, it leads, classify the group according to the outcome, the lung cancer, while the other cohort studies classify the patient according to the exposure, which is the smoking, just the take-home message. Again, you might use something called odds ratio in this and the other relative risk, etc. I'm going to leave this part to him. Right. We said it might be level 2 or 3. So a properly done comparative prospective cohort study, if it's properly done, it might be considered to be level 2 in some cases. What is level 1? We are going to approach what we call randomized controlled trial. And basically, most of you might have seen, read about these. Whenever you compare, like for example, you have a fractured tibia patient. You are going to put for this patient, randomize them blindly or whatever, single or double, whatever. One will have reamed interlocking nail, intramedullary nail, and the other unreamed intramedullary nail. And to be, just to reiterate, this is a kind of observational or experimental. The randomized control trial has to be experimental. And again, you are going to randomly assign those 2 groups of patients. Each group will have a certain type of treatment or procedure, one surgical, one conservative, etc. How are you going to random them? There are quite a few ways. The most important thing is to do proper randomization. Sometimes by computer-generated tables, sometimes by block techniques, sometimes by just, we've done this in Qasr al-Aini, alhamdulillah, and it has got published about crossed wires versus 2 lateral wires in the supracondylar fracture. What we used to do is basically, we've done about 60 envelopes sealed opaque. ما ينفعش تبقى شفافة. فيجي النايب اللي عايز يمشي ايده في اللاترال يقوم باصص كده حاططها على النور، وده كان بيحصل بره. يقوم جايب لمبه وباصص عشان من الظرف يبص هي 2 لاترال ولا، فلازم يكون sealed opaque envelope. That's one of the ways. في حاجه اسمها quasi randomized. It's basically they go randomization using the date of birth of the patient, the admission. This is not quite a proper randomization. ليه؟ ممكن واحد يكون عارف ان هو يوم الثلاث هيدخل له العيان اللي هو هيتعمل له، فيبدا يبعت عيانينه يوم الثلاث اللي هو حابب يعمل لهم رين نيل. فدايما الالوكيشن عشان نتحاشى الالوكيشن or selection bias we have to do proper randomization. ده طبعا باختصار. Advantages, this is considered to be the highest level of evidence available. And actually it's very good chance to be published. وده اللي حصل مع البيبر بتاعتنا. Disadvantages, it's very expensive, time consuming. And again, only narrow question can be addressed. شايفين هنا لما جينا نتكلم عليها, again, formulating the proper question, this is very important in the design of your study. Sometimes it has some ethical issues. هو دلوقتي ينفع ethically ان اقول ان انا هخلي ناس مثلا for example ما ياخدوش treatment مهم جدا للديابيتس وقارنهم بحد او حاجه لايف يعني حاجه ما ينفعش اعملها ساعات. Whenever it, you need to randomize, you have to make sure that you have ethical approval for that. It's not ethical ان احنا نقول مثلا دلوقتي انه ما ينفعش نعالج الاوبن fractures by XYZ، هنسيبه في جبس. Is that acceptable؟ وهنراندومايز. فاهمين يا جماعه؟